We are now going to hear about the mental health factor and talk about building some resiliency during a pandemic or during a disaster. We'll hear first from Dr. Jose Maldonado. He's the medical director of the Psychosomatic Medicine Service here at Stanford Healthcare. Followed by Dr. Eyal Fruchter. He's the director of the Division of Mental Health at the Rambam Healthcare Campus. And finally, Dr. Debra Kaysen, who's a professor in the Department of Psychiatry and Behavioral Sciences here at Stanford, and is also the president of the International Society for Traumatic Stress Studies. So, Jose, let's start off with you.
So, hi, as Mark said, I'm the chief of consultation liaison psychiatry and the emergency psychiatric service here at Stanford. And I'm going to focus primarily on the psychological toll of disaster events. Of course, as we will expect with the waxing and waning of the pandemic, and unfortunately, we are now kind of right here, we will expect that patients will experience new psychiatric symptomatology, either from the direct effect of the virus itself on the central nervous system, the experience of being sick in the hospital, or being worried about being sick. Or of course, there's also secondary traumatization for the family members of those who are lost. We do know and expect that patients who have pre-existing psychiatric disorders like depression, anxiety, and psychosis will have new exacerbations. And we know from the Substance Abuse and Mental Health Services Administration that there has been a 1,000-fold increase in the use of their hotline. Similarly, there has been a 47% increase in utilization of the suicide hotlines in the United States as of June of this year. Now, COVID itself probably has direct risk or effects on mental health and the possibility of suicide for a number of reasons, right? There's a issue of social isolation, decreased access to usual community resources, including religious support. There's the issue of the disease itself. There are side effects that include neuropsychiatric complications from the treatment for COVID itself. And then, of course, there is the barrier to mental health. And probably in these days, we need to add the seasonal variation rates that normally will occur with some of the mental disorders and the fact that we are now approaching that kind of season. When we look directly at the impact on COVID-19 patients, in a study on Wuhan, initially was reported that nearly 100% of the patients experienced some form of anxiety disorder. Other studies have looked at mental illness in patients who have been hospitalized. And you see here that 30% of patients admitted and recovering from COVID-19 experienced depression, as opposed to those in quarantine. It was only 1/3 of that. There have been a number of questions about what exactly leads to the increased mental illness in patients with COVID-19. And besides the emotional response that I already talked about, we also need to remember that there are direct effects on the CNS from the virus, and probably there is a good effect or a significant effect from the secondary cytokine storm that happens on these patients. So for example, we have been doing a study following patients with delirium here in the hospital and elsewhere. And we know that among non-ICU patients, the incidence of delirium among COVID-19 patients is nearly 30%, and that increases up to 70% on patients who are admitted to the ICU. Others have looked at the issues of secondary mental disorders on patients who have been admitted to the hospital with COVID, and you see that there's a fairly large incidence of PTSD, nearly 54%, depression, 40%, and panic disorder, about 30%. When we focus on the healthcare workers, that's nurses, doctors, through all the settings, in an initial study on Wuhan, you see that there was nearly 30% of the healthcare workers reported that they had either moderate or severe disturbances in mental health. And when you look at other studies, also in China and Italy, you see that there are significant increases on anxiety, PTSD, and depression. This is a very large meta-analysis. As you see, there are nearly 60 studies included here in all the pandemics, not just limited to COVID. And you see that there's a significant higher odds of acute and post-traumatic stress disorder among frontline healthcare workers. Many factors have been listed, and I have them in the screen. But obviously, the more direct contact you have with the patient, the more of a risk to developing psychiatric disorders. Having a past history of either psychiatric or medical disorders, which might make you more prone to develop COVID. Female sex, younger age, more junior in terms of your training. And then, of course, the perceived lack of support from either society in general or your institution in particular. There's a number of protective factors, and it's interesting that many of them had to do with the support that we receive from our peers, from the institution itself, and then, of course, the access to psychiatric interventions. Now, it's interesting, and this had just been published, that frontline physicians appear to be afraid of seeking mental health. This is a study by the American College of Emergency Physicians that included nearly 900 subjects. And as you see, 42% of the respondents complain about feeling much more stress, 45% some stress. And then, of course, there was an increase in stress and burnout rates related to the pandemic itself. Some of it, as you see, 83% had to do with concerns of healthcare workers of infecting their own family members or friends. 80%, complain about being concerned about their own safety. And then 60% complain about not having the necessary resources. And you see here that 30% reported that they have excellent access to mental health treatment. 42% reported fairly good access, which means that about 30% of them have poor access. And still, despite the fact that over half of the healthcare workers reported having good access to healthcare, 45% of those in this study, which was primarily of emergency physicians, reported being uncomfortable or feeling uncomfortable about seeking that psychiatric care that is available to them. And we can later talk about why is that, but it has to do with fears about how your peers would look at you, concerns about your own employment, and more importantly, access to your future career, because in the United States, some states do track the development of mental illness on physicians, and physicians have a concern about accessing care because that might affect their future employment, privileges to hospital, and even access to their medical license. And with that, I'm going to pass it on to Dr. Fruchter, who is going to talk about interventions.
Thank you so much, Dr. Maldonado. Dr. Fruchter, let's hear from you now and talk about some of the interventions that we can employ to mitigate our risk.
Hi, I'm very happy to be here. Though in person, it's much nicer. I'll be talking a little bit about the mental health impact of mass trauma, and I'll try to focus on the early secondary intervention, which is immediately after we've met with the trauma, and how do we deal with that? And that's actually a question that makes you understand what trauma is really about. Trauma is like a balance scale. You have to balance yourself between the resiliency that you have and the coping skills that you have on the one hand of the scale, and the trauma demands on the other one. And as we've seen in the previous talk by Jose, we can understand that, for instance, if you're younger, you have higher chance of developing anxiety disorder or any problem because you have less on your coping skills and less on your experience, so the burden is much higher. Of course, the best way to deal with it is just like the cat is saying, eat, sleep, but usually we cannot and we need to work. And when we look at the literature and we focus on the secondary prevention, we can see that the main person that talked about that was Professor Salmon in 1917. And he talked about the PI principle when he was working as a psychiatrist with the American forces during the First World War. And he was talking about proximity, immediacy, and expectancy. So we are expected to work with the physicians and with our personnel or medical staff members, we need to work with them as early as possible and as close as possible to the action, to where the problem comes from. But what do we do with them? That's a very big question, and he was not talking about it. So he actually didn't say what to do, just how to do it very early, do it as proximity, in a close proximity to the front lines, in his words, and with expectancy of functioning. So we need to express that, but how do we do that? So in order to know how to do that, we can understand by looking at somebody else, and that's Lazarus. Lazarus was one of the behavioral therapists, of course, from the basic theories, and he was talking about something that he called basic pH. Now, the basic pH basically say, it's of course initials. It's initials for belief, for the A stands for affect, the emotional state. The S stands for the social, and the I for imagination, the C for the cognitive, and the pH for the physiology. And what he actually says is, keep doing what you usually do. Keep on your belief, keep on your ability to imagine, to play, to function. Keep on your beliefs, your way of thinking about things. And of course, try to keep on with the physiology. So the sleep and eat and probably practice a little is not wrong. He was talking about how to keep on going for a longer time, because if you break your regularities, you become less able to cope. And then you'll suffer from compassion fatigue, or from anxiety disorder, or from depression, or even from post-traumatic stress disorder after mishaps happens. And they do happen, because during this pandemic, we needed to take all sort of medical decisions that are not needed to be, we don't need to take them in regular days, and we needed to face a lot of harsh things like families that cannot depart from their loved ones. So when we understand it's a traumatic event and we try to deal with that, we need to keep on doing what we usually do. And in order to do that, the whole system must work very hard, because we need to change shifts and we need to change where we work. We've seen we're working in a garage all of a sudden and not seeing the light from the nice glass building. And we need to work different times, and we need to be more flexible about who is taking the kids, or even if they are watching all the time computers and television, unlike what we usually expect them to do. So we need to be much more flexible, and yet to keep on what we used to do. And the system must encourage that. For instance, by taking care of the kids, by taking care of means like time for breaks and times for workup, and to encourage that. And that's sometimes even stronger or much more healthy than sending them to a mental health somebody. So in other places, I've seen that what actually people need is for others to hear them, and we can do that by surveys. They do need to be asked what they need and to be heard of. So after we do a survey, we need to push it back. We need to do something with that, to show them that they have mentioned this and that, and we took care of that. And to protect them. They want to be protected, and they want to be prepared to what they're doing organizationally and educationally, to know, because a lot of knowledge is spread, but nobody condensed them good enough. We need them to be supported, like getting them food and care for their kids. They want to know that somebody will care for them if they get ill, and of course, if they need to go to a mental health, they need to know that we don't need to work through the stigma. So the best way we found in Rambam was to send the psychologists and the social workers and the psychiatrists of the liaison into the teams to work with the team. So they're not somebody that you walk in their clinic to get therapy. They just your friends and your comrades. They're sitting with you and they're eating with you at a coffee break. And on the way, they ask how you manage with the family and with the difference of time. And that's very, very helpful. The last thing is to keep the hope, because keep the hope is extremely important. Now, the last slide, if something bad happens, for instance, I just took care of somebody who died and I saw their family and they couldn't depart from them, or I took care of somebody and something bad happened and he deteriorated and his spouse was in the same room with him, because things like that did happen. And then I see that the personnel that took care of him, he all of a sudden, he shuts up and he sits down and he's not connecting. We need to establish what we use for PTSD, for acute reaction to stress, in the IDF and now in Rambam, and that's the short shield protocol. We need to go to them and put initial contact to make sure that they are with us. Then we need to emphasize that we're committed to them. I'm with you. You're not alone. These are very extremely important words at times like that. Then we need to gradually challenge the activation. We need to let them choose, because by choosing, we overact their prefrontal area and take less action in the amygdala area, which is currently flooded and we don't want to be stuck. So for instance, to ask them, do you want to call your kids or your husband, or do you want to drink some coffee? Now, I don't care what they choose as long as they start choosing, because that's the activation of the prefrontal brain. And next we go to a cognitive communication. So if they talk about emotions, we don't go there. We encourage them to say what they were doing, what were they seeing, what they're about to do. Because again, emotions are amygdala area. We don't want that at this extreme point. Of course, the rest of the time we can talk about emotions for as long as we want. And we need them to see the continuity, and we want them to create the orientation. I've taken care of a lot of patients. I will take care of a lot of patients. I've taken care of this patient and he died. And these are the basic rules of what to do when we see some extreme reactions. This will enable to lower the chance of compassion fatigue and make sure that the staff member will rejoin with his friends and retake his job, and then change his narrative from I missed function to I'm functioning. And now I'll move on, of course, to Debra.
Thank you so much, Dr. Fruchter. I especially found interesting the concept of essentially embedding the mental health workers with the teams rather than expecting them to make appointments and go to offices. Dr. Kaysen.
Thank you so much. And this is just a lovely segue into what I'm going to be talking about, which is for people who don't recover naturally, what do we do then? So I do want to clarify, we've been talking about PTSD, we've been talking about stress, and I think it's important to highlight that stress isn't always bad. Stress is uncomfortable, but the place where stress becomes problematic is when it's chronic and persistent. We can think about how that is playing out with the COVID-19 pandemic. When we talk about traumatic stress, we're talking about something that is much more specific. That's exposure to actual or threatened death, serious injury, sexual violence, repeated or extreme exposure to aversive details of traumatic events. And that's often in the course of our professional duties. And again, we can think about how that's playing out right now in the context of COVID. Some of the literature and some of the conversations about COVID-19 has combined stressors with traumatic stressors. When people are talking about the economic hardship, isolation, overwork, the effects of quarantine, following the incessant news cycle, those are stressors rather than traumatic stressors. What we have here in many cases is compounding of both. So we may have cases where somebody's in the ICU or intubated, the sudden death of a loved one or a coworker, paramedics who are being exposed over and over again to the loss of patients. Those are traumatic stressors, and that's where we really think about risk for PTSD. The other thing to remember is that people are resilient, even in the context of traumatic stressors, that this is common and ordinary. When we look at extreme stressors, most people actually are able to heal and recover naturally without ever having to see a mental health worker. And that's where the kinds of resilience training that my colleagues are talking about can be especially helpful, is building that resilience and acquiring that. But even in the context of that, there are going to be some people who are going to be at risk for developing more mental health, chronic mental health concerns. So just to contextualize the work that we're talking about, within those first 24 to 72 hours after an event, that's where we're talking about that initial safety and stabilization and interventions that build resilience, like psychological first aid. And you're not talking about mental health interventions at that point. In the days and weeks post-trauma, that's when people are in that natural recovery phase. And that's where we're talking about more secondary prevention. So social support, building coping efficacy, behavioral activation, which is getting out, doing the things that are reinforcing for you or that build joy in your life, and managing those reactions. Now, when we get into the post-trauma phase, that's where we're looking more at the mental health treatments. Those may occur in a specialty mental health care setting, and those are treatments for things like chronic PTSD, depression, and anxiety. And I'm going to talk just a little bit about those. Now, I think one of the challenges with the COVID-19 pandemic is we keep dipping in and out of these as we're dealing with waves and as individuals are experiencing different levels of stressors. So it's not as neat and clear cut as you might see, for example, with a hurricane or with fires. So I do want to put a piece of optimistic information out, which is that we do have specific psychotherapies and medications, just focusing in now for a second around PTSD, that are highly effective. So when we look at brief evidence-based psychotherapies like cognitive processing therapy, prolonged exposure, or EMDR, what we found consistently in the literature is over half of the people who receive these brief therapies no longer have PTSD when they finish treatment. They lose the diagnosis. And there are 5 to 10-year outcome trials that find that when we get those symptoms down, they don't tend to come back. For medications, what we find is a slightly lower rate of response than with the psychotherapies, but still quite optimistic. And even in extremely difficult contexts, we find that we can treat PTSD. Because I've had people ask questions like, while I'm in the middle of the pandemic, how can I possibly get care? This is some research that I did with colleagues in the Democratic Republic of Congo. And even in settings where there was chronic ongoing violence and insecurity, what we found was that we could treat PTSD, we could get symptoms down, and we just completed a 7-year follow-up study that found that for about half of the women, they stayed in a subclinical or recovered state following treatment. So I think the challenge when we think about rates of PTSD and those who may be at risk for more chronic mental health conditions with the pandemic is that, at least as of right now, most of the people who could benefit from care will never receive this. And I think about Jose's comment around emergency physicians who are reluctant to seek care. And that's quite consistent with the rest of the literature. So this is NASARC data. And what they found is that for those meeting lifetime rates of PTSD, only 24% of them actually utilized any kind of treatment for PTSD in the last year. And for those with current PTSD, only about 30% of them received treatment over the past year. So there's a huge issue with access to care. So I think in terms of resources for people, there are a couple of options. To bridge people, there is an increasing move towards digital healthcare and digital tools. So there are a number that are free that have been developed to target specific symptoms that are available now. COVID Coach actually has quite a number of coping resources for individuals. It targets many of the issues or many of the coping skills that my colleagues spoke about, building relaxation, addressing healthy coping, dealing with some of those problematic beliefs that may get activated in times of extreme stress. My colleagues haven't spoken as much about sleep disturbance, but about a third of healthcare workers are reporting disordered sleep following the COVID pandemic. The CBTI app is one that can help with learning more healthy sleep patterns. Move Forward is a helpful app for dealing with problem-solving tools. I think one challenge with some of these is they're a little bit more of a self-guided discovery. So you pick the tool that you want to use. They don't necessarily adapt what they're delivering to you based on your response. A colleague and I are in the process of developing an online adaptive web-based intervention that specifically will address COVID-related mental health concerns and that's targeted towards healthcare workers. And the idea with that is it actually will be adaptive as people's symptoms improve or don't, and will feed people skills based on what their current interests or needs are. Thank you.
Thank you so much, Dr. Kaysen. So we do have a few minutes left for some questions. One that came across is, have we been seeing any differential in rates of PTSD in terms of people who work either longer shifts, like 12-hour shifts or nighttime shifts, as opposed to day shifts?
I've seen recent data that, and it's not Stanford specific, it's actually a paper that's coming out soon, that longer shifts, or at least more contact, is associated with higher risk, not just of PTSD, but depression and anxiety. I haven't seen any data yet about night shifts.
Interesting. It strikes me that as we are approaching the holiday season, actually in both countries, we are also anticipating an increase in COVID infections. We're already seeing that starting now. With time, as we've become more used to modified lifestyles, which may increase resilience, but do you anticipate a worsening of the mental health issues as both the infections become more frequent and the ability to, and we have to wrestle with the decisions around seeing family and how we manage through these holidays?
Actually, we are after the holidays, so we can answer that. And it did become much harder, especially for people with older parents that they couldn't visit or they couldn't be with. And there was a lot of anger about the quarantine due to that. So this really enhanced the problem.
And given the data on the importance of social support as a means of building resilience, I do think it's a risk factor. I think people figuring out how can they build meaningful rituals and meaningful connections with family and friends over the holidays. I think that's going to be important for folks getting through.
Yes.
I think that the main problem is the not being able to utilize the usual resources. So, being with family, and the fear that, if you're finishing a shift on a week and then Thanksgiving or another holiday is coming, if you go there, you might expose them to what you're carrying. So, that will prevent you from even reaching out.
Yeah. And so many of our normal methods, as I think Debra pointed out, going to the gym, even just going out and, having a beer with friends, are not really available to us at the present time.